Okay. I'm glad to introduce the first online conference between the UMC in Vienna and the Taichung Veteran General Hospital in Taiwan this year. And today we have two topics. The first one, an expert from nuclear medicine, and the first two will be the Vietnam UMC doctors to present some interesting cases. In the first part, I would like to introduce Dr. Lin Yi-Ching. Dr. Lin, she graduated from China Medical University in Taiwan, and then she had her subspecialty training in the field of nuclear medicine in the Department of Nuclear Medicine in Taichung Veteran General Hospital. And she has been an attending physician after 2014. So with her expertise in nuclear medicine, today she will share us thoughts. There is a case of hyperpower with negative finding on the nuclear medicine. So I believe, Dr. Lin.
Thank you, everyone. Let me share my slides. Could you see it?
Yes.
Yes.
Yes. Okay. Good morning, everyone. I'm Dr. Lin from the Nuclear Medicine Department. I want to thank Director Wang for the introduction first. I'm delighted to have an opportunity of a wide range of examination and treatment, from well-known cardiac perfusion scan to few rare endocrine exam that I will talk about today. It covers multiple systems in the body, providing functional information for clinical physicians. And first, let me briefly introduce myself. I've been serving in the field of nuclear medicine for 15 years, specializing in specific fusion imaging for benign bone disease, such as ankylosing spondylitis, rheumatoid arthritis. And I also handle clinical images and treatment for endocrine disorders. Since 2017, I have been served as a deputy director of the isotope therapy wall. In addition, I am a member of the Therapeutic Committee and a board member of the Nuclear Medicine Society in Taiwan. Here is the outline of my presentation today. First, I will discuss the most common performed exams, which are thyroid and parathyroid scan. We conduct them daily. And I will also share my experience with high-dose iodine therapy for thyroid cancer. Next, I will talk about two less frequent performed exams, MP59 and MIBG scans, which can be utilized in detecting endocrine tumor. And lastly, I will introduce the isotope therapy we started this year, lutetium-177 dotatate, using G1, G2 neuroendocrine tumors. I will cover the diagnosis before treatment and provide an overview of the treatment process. Due to heavy shielding requirements for radiation protection, which include lead plates and concrete walls, our department is located on the first basement floor and the second basement floor of the first medical building in our hospital. Currently, we have 25 staff members. Gamma camera, 3 of which are specialty, 1 digital PET scanner, an RIA laboratory, and 1 radiopharmaceutical prepare room. Additionally, the isotope therapy wall is situated on the first basement floor of another building. Our department was established in 1982, and since then we have progressed from the planar image to 3-dimension fusion image, and from traditional gamma ray to positron emission image. We obtain new equipment every few years, and in 2016 we established the isotherapy wall and began actively developing medicine treatments. This includes the use of radium-223 for bone metastasis in prostate cancer, yttrium-90 microsphere for liver metastasis in colorectal cancer and liver tumors. And starting this year, lutetium-177 dotatate for neuroendocrine tumor. Okay, first, let's discuss thyroid and parathyroid scan, which utilize a paclitated radioiodine and cysteamine. Thyroid scan typically involve the use of pertechnetate and radioiodine. Pertechnetate is taken up by the functional needs, and it can be used to evaluate thyroid function and detect abnormalities such.
Hello, doctor. Can you unmute your mic? Yeah.
Okay. Okay. Pertechnetate is taken up by the functional needs and can be used to evaluate thyroid function and detect nodules or inflammation. Radioiodine 131, on the other hand, is often used for thyroid cancer images and treatment. It absorbed by NIS2 and trapping the colloid, allow for visualization of the thyroid nodule and assessment for thyroid cancer metastasis. Here are some common diseases that we use pertechnetate. We use it to identify the location of atopic thyroid tissue, particularly in infants with congenital hypothyroidism. In the left image, we can see two different infants. One shows trace accumulate at the sublingual thyroid gland, while the other does not show any trace accumulate in the neck and mediastinum, indicate the absence of both original and atopic thyroid tissue. Compared to neck sonograph, pertechnetate has higher sensitivity and specificity in atopic tissue, identify the function status of the nodule. For example, in these images on the left, the nodule demonstrates higher functionality. The rest of the thyroid lobe seems to be suppressed by the hard nodule. While the image on the right, the nodule appeared as a cold nodule. According to literature, this is a 10 to 30 risk of malignance in such cold nodules, so it needs further evaluation. We use radioiodine to calculate the thyroid uptake ratio by measuring the residual ratio of the trace 24 hours after administration. The normal range should be between 15 to 40%. There are several methods to utilize. First, use thyroid probe. We use this machine to show the residual radiation level in the neck. Patient will sit in front of the probe, and the radiation level in the neck is measured. Second, as I show in these images, we also can calculate using planar images and gamma counter for the standard tracer. Additionally, pertechnetate can also be used. Images are taken 20 minutes after injection, and the functional, we will use formula to calculate the value of the uptake ratio. There are other indications that we can use radioiodine, such as pretreatment evaluation for hyperthyroidism. We use it to determine the appropriate radiation dose according to the uptake ratio and also the thyroid volume. Next, we discuss the radioiodine therapy for thyroid cancer. After total thyroidectomy in thyroid cancer patient, we classify patients into 3 different risk categories based on the pathological reports. But there are tumor remnant at the surgical margin, lymph node metastasis larger than 3 centimeters, or no distant metastasis to other organs. We give them higher doses of radioiodine. The detailed classification are shown in this left and middle images, where we follow guidelines published by the American Thyroid Association and utilize special pathology staining to prove clear prognosis information. We also establish our own thyroid cancer treatment guideline, as shown in the right images. The treatment stage for patients are determined through discussions among surgeons, endocrinologists, and also nuclear medicine physicians. Here are some examples. If the tumor resection is highly successful, the purpose of using radioiodine is to clear any remaining thyroid tissue. We will use 30 to 80 millicuries. As I shown in these images, where tracer accumulate is observed only on the right thyroid bed. You can see the image of spacity. Tracer hotspot at the right thyroid bed is noted, without any abnormal accumulation elsewhere. This pattern is commonly seen in patients who undergo first regimen of the radioiodine after surgery. However, in some cases, as I shown in these two images, regional lymph node metastasis or distal metastasis are evident. We may use higher dose from 100 to 200 millicuries according to their conditions. On spacity images, tracer accumulate can be seen in the multiple lung nodules and the pelvic bones when the post-operative radioiodine therapy. The image shows distant metastasis. We must also consider whether the patient requires additional intervention, such like local radiation, or possibility of refractory thyroid cancer. There are several pitfalls. In the first patient, only tracer accumulate in the head and neck region is noted on his planar images. Initially, we seems relatively normal. However, on the SPECT CT images, unexpected tracer accumulate in the brain here is discovered, confirmed this is a brain metastasis due to the potential risk of brain edema and sudden death associated with radioiodine therapy. So guideline recommends that patients with brain metastasis should undergo external radiation or surgical intervention first, rather than radioiodine. Fortunately, these patients do not experience any adverse effect after this treatment. And furthermore, other tumors, whether benign or malignant, can also obtain radioiodine, such like this one. We can see faint uptake in the pelvis, which is prostate cancer. Patient receive surgery and prove pathologically is prostate cancer. And even bladder cancer can also show here is a faint uptake in the pelvis, and also prove is a UCC after surgery. Another one can be very interesting is a stroma ovary. So various kind of gynecological conditions, such as uterine myoma, can also obtain tracer. So therefore, careful consideration is required when encountering unusual accumulation. Here is the number of cases of radioiodine therapy we have performed over the past 4 years. Each year, we have more than 200 cases, with approximately 75% of them receive higher dose therapy, which means patients need to be admitted to the isolated ward, take medication, and remain in isolation until their radiation level decreases. In addition to radioiodine, we also perform other isotope therapy. Here is the number in the past 4 years. And now we talk about parathyroid. Some MIPI scans are commonly used for parathyroid images, which have identified their locations and many abnormalities such as adenoma and hyperplasia. This image technique is particularly useful in preoperative location in patients with hyperparathyroidism. After administrative tracer, we obtain imagery at 2 different time points. One is 15 minutes early phase, another is 3 hours delay phase. As I show in the left image, planar image reveal 3 small hotspots here: right upper, left upper, and left lobe. And you can see the spacity images. provide more precise localization. And this location is crucial for preoperating planning. And sometimes unexpected finding occurs, as are shown in these images. We can see the planar images here on the right side. You can see some fan uptake in the skeleton. And on the spacity images, we can observe the chest accumulation in the chest wall. And this indicates a common complication of hyperparathyroidism. This is a brown tumor. Since sestamibie can also accumulate in tumor cells, any unexpected finding typically require further evaluation. For this table, we can see that even when sestamibie is solely observed in the neck, there are still many other possibility causes that need to be differentiated, such as the thyroid nodules nearby, and when the gland, parathyroid gland volume is small, and the nearby thyroid nodule may show prolonged and avid chest uptake. So compared to ultrasound here. Compared to ultrasound, sestamibie still perform better, especially in localized atopic thyroid gland, atopic parathyroid gland. Okay, let's move on to spasticity for endocrine neoplasm, which we use radioiodine 131 and B59. This is a 62-year-old male patient. He went to our hospital because adrenal incidentalloma was found in other hospital. We performed MP59 scan with dexamethasone suppression. On the third day after tracer administration, we can see that tracer accumulates is observed in the right adrenal gland, which is better seen on the spasticity images. Spasticity images also provide better identifier of physical uptake in the gallbladder, which may mimic adrenal uptake in the planar images. So after surgery, postoperatively, the lesion is confirmed to be an adrenal cortical adenoma. Here is another patient. This is a female patient present with hypertension, abnormal ACTH, and cortisol level in other hospital. In our hospital, the laboratory data are all within normal range. However, in her, the image shows significant abnormal tracer accumulates in both sides of the adrenal gland, which become more pronounced. We can see it clearly on the spasticity images. Spasticity images clearly localize the accumulation in both sides. Here is the right side, here is the left side, and confirm bilateral adrenal adenoma. Abdominal CT was done in this March, and these two lesions shows no apparent change. They are relatively stable. And since the patient showed no symptom at all now, so we suggest her close-up follow-up. MIBG scan. MIBG scan is a scintigraph study that uses norepinephrine analog labeled to iodine 123 for diagnosis, or iodine 131 for both diagnosis and therapy. MIBG scan is positive in several kinds of endocrine tumors, such as neuroblastoma, pheochromocytoma, or paraganglioma. And images are taken at 6 and 24 hours after administration. This is a 18-year-old boy present with a neuroblastoma in his left retroperitoneum, which shows liver, bone, and multiple abdominal lymph node metastasis when diagnosed. You can see here, he have underwent a lot of treatment, and while some residual lesions were still noted in the follow-up CT scan, So we perform one radioiodine 123 MRBG scan for him to evaluate the tumor activity. In our images, you can find that the cystic lesion in the retroperitoneal region and the right para-aortic lymph node shows no abnormal maybe uptake. So this lesion might be tumor is not likely in these lesions. And the residual structure may be due to post-therapy reaction. Here is another example of 123 MRBG scan. This is a 6-year-old male boy and presenting with neuroblastoma of the left adrenal gland here with lymph node metastasis and bone marrow involvement when diagnosed. And after tumor excision and several treatments we can see here, we perform MRBG scan for evaluating treatment response. In our images, we can see the left retroperitoneal region is clear without obvious tracer uptake. However, tracer accumulate in the skeleton. Here, especially in the pelvis and the femur was noted. So it indicates residual bone metastasis. This patient needs further treatment. So finally, let's move on to the highlight of today's neuroendocrine tumor. Here, let me explain the concept of theranostic to everyone. Due to the ability of radiopharmaceutical to emit different types of particles, such as alpha, beta, or gamma particles, we can not only use the longer range gamma rays for imaging purpose to aid the diagnosis and staging, but also we can use a short range with higher energy particles such as alpha and beta particle to damage cell DNA for therapeutic purpose. Sometimes radiopharmaceutical use the same ligand to bind with the same target, or even some pharmaceutical can have a different particle at the same time. Therefore, we can use them for therapy and diagnosis at the same time. That means we see what we treat and we treat what we have seen. So neuroendocrine tumor cell possess special receptor called somatostatin receptor. By utilizing the binding property of the receptor to peptide, when gallium-68 binding to dotatate, we can use it as a positron imaging, can map the distribution of tumor. When lutetium 177 binding to dotatate, which brand name is Lutathera, therapeutic effect on the tumor are achieved. This treatment known as PRRT is now a standard treatment for neuroendocrine tumor. It is used in patients who still have symptoms despite medications or who cannot undergo surgery treatment due to distant metastasis. Before treatment, patients will undergo both FDG and gallium dotatate PET scan simultaneously. The more well differentiated the tumor, the higher uptake of dotatate will noted. While the poor differentiated tumor tend to have higher FDG uptake. As shown in this image, when pathology reports show the Ki-60 index is less than 20%, the gallium PET reveal the tumor and making the patient suitable for PRRT. However, when the Ki-60 index is higher, like this patient is 90%, the tumor shows strong FDG accumulation. This kind of patient not only have poor prognosis, but also are not suitable for Lutathera therapy. Follow the design of NATURE-1 trial. Patient with functional neuroendocrine tumor located in the midgut present low to intermediate differentiated. And a positive somatostatin receptor image like gallium dotatate scan or ultriotype scan can benefit Lutathera therapy. Lutathera therapy improve overall survival and disease-free survival in this kind of cancer. Okay. We use FDG PET scan and gallium dotatate PET scan to evaluate patient. Patient can be classified into 5 categories. When gallium PET is positive and the PET scan is negative, we know less is a net PET score 1. This kind of patient are accepted to have the best response to Lutathera and the most favorable prognosis. Conversely, when the FDG PET scan is positive and the gallium PET is negative, known as a net PET score 5, this kind of patient are not recommended for Lutathera therapy and have the poorest prognosis. Okay, before patients are admitted to our isolated ward, waterproof and dirt-proof paper is laid on the floor. This tape is necessary to prevent environmental contamination from patient vomit, which may happen while the amino acid infusion. Upon the arrival of the medication, the integrity of the outer package is confirmed. Then nuclear pharmacists use calibrator to verify the activity dose of the medication. Typically, the medication is prepared 2 days. The process of Lutathera therapy takes 4 to 5 hours. First, we will give patient antiemetics, followed by the infusion of amino acid to protect the kidney, which lasts for 4 hours. And 30 minutes after start the amino acid, Lutathera is infused use gravity method. Okay, as shown in these images, normal saline is injected into glass vial above the liquid surface using a shorter needle, and while a long needle connects from the bottom of the glass vial and direct to the patient. During this process, we can use detector monitoring the radiation level and initially reach the peak when we open the vial and gradually decrease throughout the infusion process. Yes, from 66.8 to 7.2. So after 25 to 30 minutes of infusion, a stable low radiation level indicates that the completion of the infusion. The complete treatment regimen requires 4 doses of Lutathera, and each dose administration 2 months apart. And during these 4 Lutathera treatments, the long-acting ultriotype medication need to be temporarily stopped 1 month before, and we will resume it on the day after each Lutathera treatment to achieve the best therapeutic effect. Okay, let's move on to discuss the case received Lutathera therapy recently. 2 weeks ago. This is a 63-year-old woman who was found a tumor in the pancreas head in 2019. At that time of diagnosis, the tumor had invaded to gallbladder and metastasized to liver. And due to the large size of the tumor, she underwent gallbladder removal only and liver biopsy at that time. The pathologic report index neuroendocrine tumor with Ki-67 index of less than 2%, Sandoz starting large, and underwent several TAE procedures for the liver metastasis. However, she began experiencing recurrent GI bleeding symptoms last year and received blood transfusion for several times, and even the palliative radiation. Her gallium delta TET here and the FDG PET scan both shows positive finding, but the gallium delta TET reveal more uptake here, more significant trace uptake, and more liver metastasis. So the net PET score was 2, indicate that she is suitable for lutathera therapy. And these are the images taken the day after she received lutathera therapy in the first time and the second regimens. We found that during the first treatment, the location where the lutathera accumulation is closely resembled the gallium PET. Then you can see here, SPECT image shows a significant trace uptake in the tumor. But in the second treatment, we noted that tumor have reduced the size. You can compare two SPECT images. But the trace accumulate decrease from Kranick score of 4 to Kranick score of 2, which means the uptake here in the second time is less than the spleen and equal to the liver. Therefore, we are worried about the therapeutic effect. So we would decide to follow up the other image 1 month later to confirm the treatment efficacy before deciding whether to proceed with the third decrease. And she did not experiencing dry breathing symptoms anymore. So, and her blood test and kidney function remains stable without any decline after these two regimen. So overall, this patient responds to lutathera therapy and appear promising with no side effects noticed so far. Okay, here are take-home messages. First, pegnetate can be used to visualize the morphology of thyroid nodule and detect any ectopic thyroid tissue in case of congenital hypothyroidism. Radioiodine is employed to assess thyroid function, whether it's hyperactive or hypoactive. And higher dose radioiodine can effectively treat thyroid cancer, providing additional staging information through post-treatment images. Moving on, sestamibi images helps location hyperfunctioning parathyroid gland. MP59 identify the adrenal adenoma. And MIBG image shows endocrine neoplasm for treatment response and a sign of metastasis. Lastly, we explore the concept of theranostic, which is involving using receptor peptide binding property to combine different radioisotopes for different purposes. Okay. Back to the timeline. In addition to the exam and treatment I talked about, by the end of 2024, we are going to introduce new treatment and new equipment. This includes the using of lutetium-177 PSMA for treating prostate cancer, and SPECT scanner capable for rapid whole body SPECT scans, and AI assist whole body PET scanner and PET MR scanner. And we also use the auto syringe pump system to reduce the radiation exposure for our staff. So we look forward to our department growing stronger. And today I will provide a quick overview of nuclear medicine imaging and therapy we use for endocrine disorder. The time of introduction is short, and there's much more to share, especially since clinical image often differ from the textbook standards. Typically require the experience of the nuclear medicine doctors and close communication with clinical physicians. Of course, I want to express gratitude to our patients for their trust in our medical team. And thank you all for listening.
Okay, thank you, Dr. Lin, for your presentation. And good morning, Dr. Nam. Is there any questions from the audience?
Okay. So any question? So I just have one question for Dr. Lin. So your talk is very comprehensive and a lot of information and advanced technique. So maybe something we don't understand. So we want to ask you about thyroid cancer treatment. So any advance in nuclear treatment in thyroid cancer now in your center? So for example, a patient they have thyroidectomy because of thyroid cancer. They have the total thyroidectomy. So any new techniques in nuclear treatment now in your center?
Okay, thank you for the questioning and shows more precise location of the tumor. So we want to emphasize specificity use in every patient. Currently, we use only local specificity in the neck region, but we want to we will use whole body CT for following two patients. If we have obtained the new equipment at the end of this year, so I hope we can detect more detailed lesions by the new equipment. Another one is PET, FDG PET scan. We always obtain radioiodine scan for thyroid cancer patient, but I think we should put FDG PET scan in this kind of patient too, because some of the thyroid tissue, cancer tissue, is poor differentiated, which cannot be seen in radioiodine images clearly. So I think we should perform FDG PET scan in all this kind of patient when the thyroid cancer shows aggressive behavior, shows a lot of regional metastasis. So maybe we will put it in our routine scans.
Okay. So is there any further comments? And the Dr. Ying also shares a recent treatment and the case about Nucera for some patient with NETs. And I would like to ask if Professor Nam, do you have some kind of treatment experience for patient with NET in your hospital?
Yes, actually, about talking about neuroendocrine tumors in our center. Actually, we don't have much experience in this field yet, because normally patients who have neuroendocrine tumors, they usually admitted to general surgery, and they have surgery. After that, we found NETs after we have pathology, and we work up from that. And after we have diagnosis of NET, we will have a meeting with oncology and surgery, and we try to find the treatment which is appropriate for the NETs. And sometimes we use like sandostatin to control the symptom, and sometimes oncology, they can have some regimen for NETs. We don't actually we don't have many patients yet. So Dr. Thắng, we will have some comments.
Actually, in Vietnam, we don't have the PRRT therapy. So actually, the patient will treat with the surgery or medical treatment with sandostatin only. So in case the patient not like respond to that treatment, some patient sometimes we send outside to Singapore for PRT treatment, but only a few patients.
Okay. Yeah. Actually, we also do not have many patients. Just like your experience, most of these patients were firstly seen by doctors in the general surgery or the department of cancer treatment. So we do not have many patients, just like your experience. But the Dusteva treatment is also new for us. So Dr. Lin and the Department of Nuclear Medicine started this year, and we still in just try to accumulate our experience in this kind of treatment. And in the future, if our process is mature, maybe some of your patients could be transferred to Taiwan as well. I think that that's maybe a possible pathway in the future. Just a comments for the discussion.
Can I ask for the fee? Is it expensive for the PRT treatment?
Oh yeah. Before Dr. Lin's answer, so in the previously when you transfer a patient to Singapore, how about the fee?
It's around like $5 per yeah. 5,000, yes, 5,000 US dollars, sorry.
5,000.
For one circle, yeah, for one circle. Because usually the patient need like 3 or 4 circles.
Yeah, for one circle, okay. So Dr. Lin, would you like to?
In our department, the first patient pay 26,000 US dollar for one regimen, and another 2,000 for the process fee. The cost is very expensive. But recently we have some transfer from other hospital in our central region of Taiwan, and because other hospitals and medical center in central Taiwan don't have PRT too, so they will transfer their patient to our department. They will transfer patient to hematology department first. Then the hematology doctor will cooperate with us and show how we can process therapy to this kind of patient.
So it sounds like the cost here is expensive than Singapore for each cycle.
26,000.
Is that okay? So I wonder why there is the kind of difference.
I remember the drug. The medication is produced in Singapore, so maybe the transport fee is lower.
Okay.
Because the drug is made 2 days before, and the radiopharmaceutical has half time, so they decline over time. So when you transport to Taiwan, it need take times. So I think maybe the transport time make the fee increased.
Okay.
So today we have one more question for Dr. Lin, because you are very good at radiology, scintigraphy, and something. So we have many cases with hyperparathyroidism, but negative scintigraphy. In our country now, we usually use delay technique with technetium sextamine. But how about previous technique, subtraction technique? Now, do you use this technique, subtraction techniques scintigraphy for hyperparathyroidism tumor?
We encounter the same problem on hyperparathyroidism, because hyperparathyroidism, especially hyperplasia cell, they are small, they are tiny. So on plant eye images, we could not see them directly sometimes. So we perform spasticity in every patient. And we perform spasticity on delay phase, 3 hours or 4 hours later after administration of tracer. So the thyroid or other muscle uptake or blood pooling around neck will wash out. So the spasticity images which I show, let me transfer to the, it's crap. Okay, I show make the slice more thinner, even 2 millimeters in each images. So I think in order to trace optic, we also can use anatomy images combined. So that is benefiting in spasticity. We cannot use functional image only, but also the anatomy images together. Sorry, I can't hear you.
How about all the technique, subtraction technique?
Yeah,
subtraction
I know that.
technique.
Yeah, but we don't use it because it needs more time to calculate and manual process by human. So nowadays we don't use it. I know some less common PET tracer for parathyroid gland, such as fluodopa, F-dopa, but we don't have the agent, so we don't perform it. So nowadays, if we want to improve our spasticity images, maybe we can take later time to perform the spasticity, and maybe we can use a new technique, new equipment for obtaining our images.
Yes. Today we also invite some doctor from nuclear medicine department join us. So any other question?
Hello.
Yes.
Can you hear me?
Yeah.
Yes.
Okay.
Please.
My name is Jun-Sing Wang from the Nuclear Medicine Department of Rai Hospital. I'm very happy to hear your presentation and to learn a lot from you. We also do some technique concerning with the nuclear medicine in the endocrine service. We also do the thyroid treatment and parathyroid scan, and the same to your technique. We do the delay scan with the MIB. I think with the delay scan, the MIB is better than the technique subtraction. In the past, we also do with the thallium and for technetium for the abstraction. But the problem is the radiation to the patient. That's why nowadays we also do have a sector MIB scan with the 2 phase. The first phase in around 20 minutes and the second around 2 hours. And I see you do 3 hours. I think some case After 2 hours, it's not clear. If we can do more delay, 3 hours. And concerning with the endocrine tumor, from last year, we start this with the gallium DOTA scan. Until now, around 6 months, we do around more than 30 cases with PET-CT with the gallium DOTA. It's very good for the neuroendocrine tumor with the grade 1 and 2. We try to see some cases with the grade 3 and also for the neuroendocrine carcinoma. And we found that FDG PET scan is better than gallium scan. It means that with the gallium scan is good just only for grade 1 and 2 neuroendocrine tumor. We also do until now around 55 cases with the gallium BSMA. Concerning with the BSMA PET-CT, it's very good, very good. We found a lot of the patients with the recurrent in the biochemical recurrent, and we found a lot of the lesion to help the doctor in the oncology. The future of what we thinking about how to treat the patient with the neuroendocrine tumor and prostate cancer with the lutetium. I also learned from you about the lutetium DOTA for the treatment. I hope one day I can come to you and to learn more and more. Thank you so much. Thank you so much. Yeah.
Okay. Thank you for your comments. Yeah. Any more comments from Dr. Lin?
I have some query concerning with the gallium DOTA. How about for the patient with the pheochromocytoma? We can use the gallium DOTA for detection of the patient pheochromocytoma.
Yes, because we don't have gallium DOTA pads in our center. Nowadays, there are 3 hospitals in the north of Taiwan. They have gallium DOTA pad only. So we transfer our patient to the medical center in the north of Taiwan. They undergo the PET scan, gallium pad scan, and we transfer the image to our clinic. So we hope we will have a gallium DOTA pad next year after we reconstruction our radiopharmaceutical prepare room. Then we can produce it by ourselves. But nowadays we cannot obtain gallium DOTA PET scan in our patient in our hospital. So we only have experience in radioiodine 123 MIBG scan. We only have this experience in glaucoma. And you know that the radioiodine's quality, the image's quality of radioiodine is less than the gallium PET. So you can see showing my slides, I only show the 6 hours image, because after 6 hours, 24 hours, or even 40 hours in the textbook, the images is not so good in radioiodine. So I hope we have gallium PET next year, then we can perform gallium DOTA in leukocytoma patient. But I hope so. One day we can use it.
Thank you.
Okay.
Gallium
Thank you, Dr. Lin. Okay, but hopefully we can have it soon in our hospital available for some patient. So maybe in 2025 you can share with us again about this kind of treatment.
Yes, I hope so.
Okay. So is there any comments or questions? Okay, so it's about time to move to the next section, and now we thank Dr. Lin again.
2 cases about parathyroidism, and we will present both 2 cases, and then we will have ask for comment from you and participant. So Dr. Nhi will present. Please.
Thank you for Dr. Nam for the kind introduction, and good morning, Dr. Wang, Dr. Trình from Taiwan, and good morning, everyone. And thank you for having me today. My name is Phạm Yến Nhi, and I'm a doctor in endocrinology department. And after interesting presentation about radionuclide of Dr. Trình, and I'm really excited to talk about some clinical cases to discuss the role of imaging in hyperparathyroidism in a University Medical Center in Ho Chi Minh City. Yeah, and I will present 2 cases today from our clinical perspective. And the first one would be a patient with primary hyperparathyroidism with a negative ZMBB scan. And the second one is a hyperparathyroidism after a kidney transplantation. And let's move on to our first case. And this is a 68-year-old man came to us with the chief complaint of prolonged constipation, and he has been having this symptom on and off since 2020, and it seems not resolved with any laxative, and is causing fatigue and discomfort, and sometimes he's experiencing a loss of appetite, polyuria, especially at night, and excessive thirst. And 1 week before came to us, everything radio got worse, and so he visited to local hospital with abnormal result, and we can see a hypercalcemia, and increase the PTH level, and CT scan with a suspected left parathyroid adenoma. And moreover, the patient denied any other symptoms, for example, pain, fever, sudden afraid, muscular weakness. And he was referred to us for further assessment. And for the past medical history, he had hypertension, cardiovascular with 1 stent and 1 bypass grafting. And it's worth noticing that he underwent a lithotripsy for the kidney stone in 2010, and continued to have a rapid recurrence formation of kidney stone without any further treatment. And more example, we have 0 access to the previous electrolyte, and he's on a medication for the CVD. And overall, his physical examination revealed no abnormal size, and we can see the thyroid is not enlarged, no visible or palpable mass in the neck area. And then we have run some labs and imagings. And as you can see, the child elevated calcium, a low phosphate, and remarkable high of PTH level indicate primary hyperparathyroidism. And you can see luckily his kidney function and vitamin D level remain normal. And on the thyroid ultrasound, we can see a lesion in the lower of the left thyroid globe, around 15 by 6 millimeter inside, possibility a lymph node or a parathyroid node. And we also notice in the abdominal ultrasound, he has multiple bilateral kidney stone and gallbladder stone. And in the next step, we use ZBB scan to determine functionality of the suspecting tumor. And we expected to know if this tumor is hyperactive and causing hypercalcemia in this patient. However, there was no abnormal radial uptake in the parathyroid gland. So we combine another imaging, a CT scan. And in the next CT scan with contrast, we can show a lesion in the lower posterior of the left, on the left thyroid lobe, possibility of parathyroid adenoma. And in spite of a negative ZBB, after combining of history of clinical examination and lab results and CT scan imaging, we still decided to take him to the operating room, and we apply the intraoperative PTH monitoring method. And we expect if the PTH level post inscription drop more than 15% compared to the baseline, we can confirm the successful removal of the functional tumor. And in this case, we learned that the patient PTH level dropped more than 18%, and we can see the histopathology. We have a parathyroid adenoma. It means we have a successful operating remove the right tumor. And so to wrap up, in the first case, I would like to listen further insight from Dr. Jing and Dr. Wang from Taiwan, and some experience about this point. And the first is the role of radionuclide imaging in primary hyperparathyroidism. And secondly, we want to discuss some factors impact the ZBB scan accuracy. And finally, how do we handle a hyperparathyroid with a negative ZBB scan, and what the challenge in surgical planning and addition imaging we can order to hire a more accuracy diagnosis. And radionuclide imaging in primary hyperparathyroidism have us to reach ultimate goal. It means to ensure complete hyperactive tumor detector and active remission. And similar to the presentation of Dr. Jing, remind in the previous, by radionuclide, we can verify which gland is hyperactive, because in many cases, there are more than one hyperactive glands, and we can miss some tumor because in imaging finding due to the small size or atopic location. And thanks to accuracy locating, we can reduce the risk of bilateral neck exploration by minimal invasive surgery. And finally, with radionuclide imaging can help to monitor and follow up the patient with the persistent or recurrent hypercalcemia after surgery, because some residue hypergland. And moreover, although radionuclide imaging is very helpful in many cases, we still need to keep in mind some factors that influence the results. For example, small size tumors lower 500 milligram or a lower concentration of oxyphil cell is harder to detect. Moreover, multiple gland disease with a different uptake may give confuse the imaging finding. And for the tumor in some difficult location may be missed in a sesame scan, or in the patient with a coexisting thyroid disease, including a goiter or a thyroid knot, they can mimic. And so when we face a negative sesame scan, what are the challenge and what can we do the next? And we can see without the guideline of sesame B, the patient have a higher risk from the bilateral neck exploration and risk of persistent or a recurrent disease. But in nowadays, there are more advanced imaging technique and intra-operating PTH monitoring that we can combine to increase the successful rate or complete removal. And in the end, I want to remind it's important that we work as a team, including endocrinologists, radiologists, oncologists, and surgeon to manage patients with negative sesame B scan with a parathyroid gland. And next, I'd like to move on the second scale related to a patient with a hyperparathyroidism after a kidney transplantation. And this is a very young patient, a 48 years old man with uncontrolled hypertension, and he has a history of severe infection and a long history of end-stage renal disease, requiring over 20 years of the dialysis. And finally, he underwent kidney transplant 5 years ago. And then he couldn't remember exactly when these symptoms start and appear after kidney transplantation, including a dull headache, which comes and goes several times and is get worse, significant lower quality of life. And his CT and MRI scan of the brain showing no abnormal. So he continued taking painkiller, and he reports some symptoms, for example, a bone pain, particularly in knee bone, and it's difficult to walk, but without any deformity. And he denied any symptom, for example, weight loss, polyuria, or excessive thirst. And as we can see, he is on the medication related to the kidney transplantation and CVD. And it's worth noticing we have a 0 previous electrolyte result and kidney stone. And his examination is unremarkable. And we have some lab and imaging, and we can see we have elevated calcium with a low phosphate and remarkable high PTH level, and it indicates inappropriate PTH level selection in a patient with kidney transplantation. And luckily, the kidney function and the ALP level remain normal. And on the thyroid ultrasound, so a hypoechoic structure around 10 by 10 millimeter inside in the parathyroid gland area. And as a result of hypercalcemia on the organ, we can see he have reduced bone mineral density with a T-score of minus 2.5 and no kidney stone during the recent follow-up in April. And unfortunately, there are no previous electrolyte tests available, so we cannot know exactly how long after the kidney transplantation he had developed of hypercalcemia. Similar to the first case, in the next step, we also use the Zetamib to determine the functionality of the suspected tumor. And in this case, we can see in this picture, we have two abnormal radio-uptake area in the lower parathyroid lobes bilaterally, and it indicates to hyperactive parathyroid gland. And then we want to locate the tumor on the next CT scan with contrast. And similar to the result of Zetamib, we have found two structure similar in location of Zetamib scan result in the parathyroid gland area. And let's discuss a bit about the first is some reason why the patient after a renal transplant may develop a persistent hyperparathyroidism. And finally, we can look at some surgical treatment indication. And we can see in the beginning of CKD patient, the parathyroid gland try to deal with the low calcium and the high phosphate by increasing PTH level. This is a negative feedback mechanism. Over time, the parathyroid cell can bigger to secrete more the PTH and leading to hyperglycemia. And later on, the cell get out of the negative feedback, and that means when the calcium level is not longer able to inhibit the PTH secretion. And in the situation of kidney transplantation, we can see kidney transplantation is considered the most effective treatment for kidney failure. And we decide to be when the patient receives a new kidney, the kidney functional return to normal, and you can see some complication related to CKD radio reserve. And the question we have, does kidney transplantation have completely resolved any complication related to CKD? In the patient with CKD, after receive a new kidney, the patient is expected normal kidney function. However, there are still many causes of hypercalcemia after kidney transplantation, and persistent hyperparathyroidism. This is the most common cause of hypercalcemia after a kidney transplantation. And after transplantation, up to 50 to 50%. Some researches show up to 80% of patients experience a persistence of hyperparathyroidism for the first year. And nowadays, there is no consensus on definition of the persistence of hyperparathyroidism after renal transplantation. But most clinicians consider a PTH level greater than 2 times normal. It around 130 to be consistent with persistent with 12 months post transplant. And there are some risk factor related to this situation. For example, a long duration of dialysis prior transplant or a higher level PTH prior kidney transplant. Some factor like size of the gland, parathyroid gland, calcium level, and high ALP concentration trial to guide this treatment. So we would think of the parathyroidectomy when nowadays there are 4 methods when we approach the surgical for the parathyroidectomy in tertiary parathyroidism. But in no consensus or guideline clearly recommendation, we have remove subtotal or a total parathyroid glands with and without thymectomy, and with and without auto transplantation. And this is important that we should balance the risk of recurrence when we remove a loss of tumor of parathyroid, and the risk of hypoparathyroidism when we remove all the parathyroid gland. And during our diagnosis process in this second scale, we find it difficult to approach because we didn't know exactly the time when the hypercalcemia symptoms start with a very skyrocket PTH level, and therefore we have approached this case for many perspectives. And could it be a typical tertiary parathyroid with only 2 hyperglycemia glands, or could it be a primary parathyroid adenoma or carcinoma in tertiary or in a secondary parathyroidism? Because we didn't know the exact timing of hypercalcemia. And then because there no consensus or a guideline, so clear recommendation for the parathyroidectomy. So we would like to hear more your experience for you in the medication therapy, for example, Siacansep, and the timing of parathyroidectomy in the tertiary parathyroidism after kidney transplantation. And thank you for having me today. And I would like to hear more your experience for you. Thank you.
Thank you, Dr. Nhi. So we go back to the first case, and we discussed the first case. Then after that, we discussed the second case. So Dr. Nhi showed some questions you raised for discussion. So I would like to invite Dr. Wang to have some comment on the first case with primary hyperparathyroidism due to adenoma. Dr. Wang, please.
Yeah, yes. Thank you for the interesting case. I think from the data, the diagnosis of hyperpara with pericytic adenoma is very clear, because you also had the passage proved. And the most interesting is that the negative image study was very clear lab evidence of hypercalcemia. So maybe Dr. Lin could give us some comments about several possibilities of false negative, or something that may interfere with the nuclear medicine image in these kind of patients for their image diagnosis. So would you have some comments?
So Dr. Trình, please.
Okay. In my experience, such small, tiny gland is difficult to see absolutely in the planar images, but in specific images, the location of the, especially in the lower gland. We know there are two pairs, two upper and two lower, especially in the two lower glands. They actually have three locations. We conducted a survey in 2016 that let me show you. Here, do you see my paper? Do you see that?
Yes.
Yes. We can
Yes,
see
we
that
can see.
in the lower gland, actually they have three locations, which is pretracheal and anterior and posterior. And in this study we conducted in 2016, it enrolled 52 patients of hyperthyroidism, and most of the upper pair of the gland were located in the posterior area, but the lower pair of the gland may be encountered to anterior, posterior, and both pretracheal area. And we found that according to their position, according to their location, actually the lower gland, which is more have higher sensitivity in images, because their location is anteriorly to or laterally to the thyroid gland, so it can be easily found. The lower pair of the gland have a higher sensitivity and specificity than the upper pair, and you can see this case. Do you see the images? This case is we obtained in March 2 months ago. You can see the planar image of this patient. Even in the 3 hours later, there is no obvious tracer uptake in the planar images. But in the spasticity images, it's different, totally different. You can see that the thyroid uptake here. And when you scroll down, you can find the hotspot here. So that is what I mean, what I said previously. In spasticity images, you can not only obtain the functional information of SPECT, and also the anatomy information from CT scan. So I think if we cannot identify small glands on planar image, then we should perform spasticity. So, that is, I think the sensitivity and specificity in the study we performed 2016 is not so good, but at that time the spasticity equipment is less efficient. But now we have better equipment, so we can detect even smaller gland and even lesser tracer accumulation. So that is my my suggestion.
So now you combine scintigraphy, sestamine, technetium scan, and CT combined, right?
Yes.
Yes.
Spasticity, SPECT first, and then CT in the same equipment. So the information is more.
Yes. Thank you. Dr. Cảnh, do you have any comment? We would like to ask Dr. Cảnh to comment. So, Dr. Wang, so I just want to ask you about how do you prevent hypocalcemia after parathyroidectomy in your center if patient undergo parathyroidectomy? So how we can prevent hypocalcemia hypocalcemia?
Yeah, so of course, the routine monitoring of electrolyte is needed, and we usually keep calcium supplement after the surgery if there is hypocalcemia. And I wonder if you have many experiences in such kind of negative energy and strong evidence of hyperpower. Do you have much experience before?
So we recently, in 1 or 2 years back, we have more cases with parathyroid adenoma. So we set up, we established the team, multidisciplinary team. When we have a case, we will collaborate. We discuss with surgeon and laboratory person, and we try to do PTH, intraoperative PTH measurement. And normally we try to measure like 25 OH vitamin D before operation. So if a patient have low vitamin D, so we replace vitamin D, because we found that if a patient have low vitamin D before operation, they may have developed hypocalcemia. And we also monitor calcemia after operation, probably in the first day of post-op, and then we monitor symptom. And normally, if PTH go down very low after operation, we have to replace calcium and vitamin D and calcium trial. So Dr. Tang will have some comment on this. Dr. Tang, please.
Because most of our patients came to the hospital with severe like hyperparathyroidism, and so it suppressed the other normal parathyroid gland. So we see a lot of patients after the surgery, parathyroidectomy, the patient develop hungry bone syndrome. So that's why, because some patients we don't have enough time to replace the vitamin D deficiency before surgery. We just like replace just few days before surgery. So we see some patients develop like severe hypocalcemia after surgery, and most of the patients develop severe one like 2 or 3 days after discharge from the hospital. So how can you know and you prevent the patient like that? So I just want to know your experience.
Yeah, previously we have some patient like surgical intervention for hyperparathyroidism or even hyperthyroidism. There might be some chances to have a complication of hypocalcemia after the treatment. So actually, we do not have some good predictor to anticipate that some patient may have severe and prolonged hypocalcemia after the surgery. But we do have some experience that some patients required prolonged inpatient care for continuous intravenous calcium supplement. I think that is very difficult to measure once the patient have hungry bone syndrome, especially for those who had uncontrolled hyperpower, or even we have some experience in hyperthyroidism, and they had hungry bone syndrome after the surgery. So this patient required continuous intravenous treatment, and of course, in-hospital care may be prolonged under this kind of complications. And I'm interested in your case. He had a upward decline, very quick decline of PTH after the surgery, right? So how about his? Yeah, how about yes, slides were very quick decline of the PTH level. So how about the cause of hypocalcemia in this case?
Em nói với anh về canxi chu phẫu.
Cái này có giảm canxi.
Did he had a severe hypocalcemia after surgery?
No.
Yeah. Yes. One day after the operation, less than 0.1. So I wonder if he had a severe hypocalcemia after surgery.
In this patient, we have no hypocalcemia after a surgery because because the patient take a calcium medicine prior the surgery. So after the parathyroidectomy, the intraoperative or PTH monitoring of over 18%, but the calcium after the surgery is not hypocalcemia. And when the patient visit the hospital to the follow-up checkup, the patient have calcemia in a normal range.
Okay. So maybe you can correct your cases that show hyperpower with hypercalcemia, but negative image studies. I'm not sure if how many cases do you have, and maybe you can correct those cases and compare with the other patient who had positive image findings. Maybe there will be some clues or some difference in their presentations that may make the negative image finding possible. I think that it would be an interesting topic to compare these kind of treatments and the patients.
So we move to the second case. We discuss about post-transplant kidney transplant. And so do you have many patients like this post kidney transplant, and patients still have tertiary hyperparathyroidism? So just show the question we discussed about so in your experience, do you have many patients like this? And when you will send a patient for a parathyroidectomy?
Yeah, after renal transplant, we have some patient, they still had hyperpower, but most of these patients were cared by the Department of Nephrology. So they, in most conditions, they keep the patient there on outpatient care. So only some severe cases we will be consulted for the management of electrolyte imbalance. But in most conditions, they keep follow up in the outpatient of the Department of Nephrology. So I know there will be some cases of these presentations, but we do really not have many experience for patients with renal transplant and hyperpower after that.
In my department, I encountered some cases like this kind of patient, hyperparathyroidism after renal transplantation. Usually the surgeon transfers them to our department because they have perceived elevating IPTH over 500. So they will consider surgery intervention. And I found that in this kind of patient, they don't show 4 glands simultaneously. Most of them show only 3 or 2 or 1. So in our studies, only half of the patients show 4 glands, obviously in their planar images. So I think, although there are 4 glands, but in that condition, maybe 1 or 2 glands will be predominant to others. So the surgeon is concerned because they will undergo removal in this kind of patient, but they have to select 1 gland to auto-transplantation. So they were concerned and use our sesame scan to select the less active gland. In my experience, some of the patients, although they remove 4 glands, on the following they still have high IPTH level, and we will find the atopic gland or even the fifth gland, and even sometimes the auto-transplanted gland in the SMA muscle or in their arms show hyperplasia. So they will use our images to select less activity gland. If our scan show very obvious tracer in the upper gland, they won't choose it as the auto-transplant gland.
Okay, thank you. So for this patient, Dr. Yi showed the result of PTH and calcium. Here we found that the PTH is not very high, and calcium is not so much high. Normally, if more than 2.9 and above, we consider this severe hypocalcemia, and if PTH very high, we will consider for parathyroidectomy, and probably I think this patient we will continue to follow up, and we give medical treatment for reduce calcium. But the patient have osteoporosis because the BMD minus 2.5. So probably patient need some medication for bone, improve bone loss. So how about Dr. Wang? Do you have any comment about treatment for this patient?
Yeah, so for prolonged chronic kidney disease, and many patients had secondary or tertiary hyperpower. I think currently the treatment is challenging because there are many complications such as the bones and also electrolyte imbalance. And I know in some countries there are some technique that could be used for the treatment of hyperpower, so-called radio frequency ablation, that micro-invasive procedures to destroy the parathyroid gland. Previously, this kind of technique mostly were used for thyroid nodules, but I know in some countries they started to do this kind of procedure for hyperparathyroidism, especially for those with prolonged CKD, but it still needs time to accumulate evidence that this kind of treatment could be safely conducted in these kind of patients. And we follow the same treatment principles as your slide. You commented for the KDIGO 2017 about some surgical indication for secondary or tertiary hyperpower. I think in this field, the advances is relatively slow especially for the medical treatment. So if in the future, if we can have some technique or micro surgery techniques that can help, I think these kind of patients may benefit from these emerging treatment. That's my comments.
Thank you very much. Any question from participant? So if there are no more questions, so I think today we have a very good discussion, and thank you for organizing this meeting for online discussion between Veteran Hospital and University Medical Center. And thank Dr. Lin Yi-Ching and Dr. Wang and all participants to join us discussion today.
Yeah.
So, Dr.
Yeah, and thank you very much for your interesting cases. And maybe as we have scheduled in the earlier emails, so I would like to keep these kind of online conference discussions about some cases, and the next time we should have some case discussions, and let's keep communications via emails in advance to prepare this kind of reference. Okay.
So we hope next time we can invite Dr. Lin talking about thyroid cancer.
Of course, I try to organize, and you know, she's very hot and very busy, you know.
Thank you very much.
And, anyway, yeah. Anyway, appreciate all of you to join and discuss about these kind of interesting cases. And
Thank you very much.
okay, so yeah, so it's nearly 1 p.m. in Taiwan because you know we have some time differences. And thank you again, and let's looking forward to next conference maybe 2 or 3 months later, and let's keep communications via emails. Thank you.
Thank
Bye-bye.
you. Bye bye.
Bye bye.